on fluids in COVID patients, perioperative fluids, fluids in intra-abdominal hypertension. And one of the last papers was a multidisciplinary report on how to start and implement fluid stewardship in your hospital. Now, going back to the 10 Ds, we have D1 on definitions. We need to speak the same language. D2 is diagnosis. D3 is distribution. Remember that every fluid will be lost through the capillary leaks. It's just a matter of time. Then we have the drug, the dose, duration, and the escalation, and we know very well about these terms because of antibiotic stewardship. D8 is documentation. We need to document what we are doing. D9, I have to admit, I asked ChatGPT, give me 10 nice words with a D. So diligence came out, and it is the carefulness in the way we treat fluids as drugs. So it's stewardship. And D10 discussion is about change and transformation, because we need to change our habits, and it's about leadership. We mentioned about the book on rational use, and I invite everyone to go to the website and download your copy. You can get a full PDF, and it has been downloaded over 1.7 million times, which tells me two things. First, people and colleagues like it when it's for free, but it also tells me that there is a huge knowledge gap and that colleagues are interested to learn and understand more about fluid management. Now, hypovolemia is bad because there are convective problems. Oxygen can't get to the tissues. Hypervolemia is equally bad because we have diffusion problems and oxygen cannot go to the tissues. And that is why the prediction of fluid responsiveness is important, as well as the fluid status. But there are lots of myths and misunderstandings. Not all septic patients are hypovolemic, because maybe they are just vasoplegic. And this is nicely illustrated in this video. As a bottle of water, you squeeze it, so you increase the stressed volume with a vasoconstrictor and you improve venous return. Peripheral edema doesn't mean that fluids are needed. And it's not just because you're fluid responsive that you need fluids, or that you're hypovolemic, or that you are fluid tolerant. Those are all separate terms. Now, I spoke about distribution, and let's dive into the physiology. We have to make the difference between the osmolality, which will determine the tolerability of a fluid, and the tonicity, which is the effective osmolality, which will determine the distribution of a fluid. The body consists mainly of water, the fluid mainly being in the cells. 2/3 and about 1/4 of the extracellular water is the intravascular fluid. Now, if you would administer 1 liter of an isotonic fluid like saline and check after 1 hour, only 250 ml would be intravascularly. If you would give a hypertonic solution like glucose, dextrose, only 8% would be intravascularly, and you can see that the vast majority is intracellular. So hypertonic solutions are good for cellular dehydration. Now, if you would give a colloid solution, then after 1 hour, at least 100% would remain intravascularly. So putting it vice versa, if you would need to increase circulating blood volume by 1 liter, for a 75 kilo man, you would need to give 12 liters of glucose, 5 liters of saline, or 1 liter of colloid like albumin. So going back to the 4 indications of fluid therapy. First indication is fluids for resuscitation, to save lives. Second, routine maintenance to cover the daily needs of water, glucose, electrolytes. Third indication is replacement, and here the fluid given should mimic the fluid that is lost. And this could be an indication to give saline if there is upper GI losses, or if you would have an high output ileostoma, then isotonic balance solutions are the best choice. Now the fourth indication is for nutrition, to cover the daily caloric needs. But what is often forgotten is that there is a fifth. It's not an indication, it's rather a consequence, which is fluids to dissolve other drugs like antibiotics, painkillers, antacids. Remember, all fluids are redistributed, so we have to reassess volemia status. Now, my colleague Niels van Regenmortel did a study in over 10,000 ICU patients, and he found that 6% of all fluids is for resuscitation, 22% is for maintenance, nutrition is about 33%, and fluid creep is another 33%. So if you take maintenance, replacement, and creep, is already more than 50% of all fluids. Now, whenever something happens to your patient, whether it's sepsis, burns, pancreatitis, fluids are life-saving and fluid balance should be positive. But then you have the second hit, which is ischemia reperfusion. The patient is keeping fluids on board, and here we have to aim for a zero balance. The third hit is a global increased permeability syndrome, the patient that is swollen up with venous hypertension and congestion, and here we have to evacuate the fluids. And when we are evacuating fluids, either with diuretics or renal replacement therapy, we must avoid hypoperfusion. So hence the ROSE acronym, going from resuscitation, optimization, stabilization, evacuation phase. And it's like a rose. The flower. You water the rose, it blossoms. At the end, it's just a dry rose. Of course, it's not a dead patient. And I'm very happy to see that this rose framework has been picked up by other colleagues, like in neurocritical care, and you can copy-paste it to burns, to severe pancreatitis, and so forth. Now, diving into the rose with the 4 hits, with a focus on the first phase. After the first hit for resuscitation, it's saving, rescuing the patient with goal-directed fluids. Now, optimizing phase is the focus on organ rescue. Stop IV fluids when no longer needed, when shock is resolved, and stabilization phase is organ support. Here we can aim for late conservative fluid management, and the evacuation phase will assist organ recovery, either with late goal-directed fluid removal, medical or mechanical, whenever there are signs of fluid accumulation syndrome. So hence the ROSE framework, the different phases, where initially isotonic balance solutions are a good first choice. If they are available, we should avoid maintenance because there is enough fluid already given. Limit the fluid creep. So if you need to give antibiotics, use glucose and use a syringe rather than a bag. Try enteral feeding, hypercaloric feeding. Remember, all fluids are redistributed. Maybe in the later phases we can think about hypertonic solutions, and albumin maybe also after 30 ml per kg have been given to limit further crystalloid resuscitation. Always think about restriction of fluids, de-escalation of fluids, withholding of fluids, not giving them when they are not needed, withdrawing, which is going down with the speed and the volume, and sometimes de-resuscitation is needed. Saline can be used in traumatic brain injury instead of balanced solutions. Now, I want to emphasize that there is nothing normal about saline because it induces an increase in sodium balance, chloride, it diminishes renal perfusion, creates acidosis. It will lead to a positive cumulative fluid balance. It will also increase potassium in case of AKI with increased potassium. and will result in higher vasopressin needs. As you can see, there's a lot of literature against saline. Now, recently came out a systematic review and meta-analysis combining the results of 6 randomized trials going from the split, the salt, the smart, the plus, and the basics trial. And the bottom line is that balanced solutions have a 90% probability of reducing mortality with 1%. And they are associated with less major adverse kidney events, especially if you combine the emergency OR ICU trajectory. So if you start with balanced and you continue in the ICU, is better prognosis. So it's also important that already in the emergency department, the correct fluids are given. So it's the first choice in sepsis, burns, pancreatitis, DKA, AKI, and not in neurotrauma patients. So focusing on the ROSE model and trying to find the literature supporting it, there are many big fluid trials, but they focus on different phases within the ROSE model. There is no one single study covering all these phases. So therefore, we should aim for rescuing the patient with goal-directed therapy, optimizing organ function, go for late conservative fluid management, stabilize organ function. Some patients may need late goal-directed fluid removal to evacuate the excess of fluids and save the patient. Now, how to guide initially? Macrohemodynamics, passive leg raise, fluid responsiveness, lactate. When these normalize, you can stop fluids. When there is an impact of fluid accumulation on organ function, venous congestion, intra-abdominal hypertension, as in my personal case and the other patient I presented, then you may need to evacuate and try to avoid hypoperfusion. Also here, there is no one single study covering these different phases, but everything you need to know about de-resuscitation can be found in this open access paper, where we dive deeper into the ROSE framework and we give some tips and triggers when to start fluids, when the patient is in shock. You stop when the patient is fluid unresponsive, shock resolved. You start fluid removal when there is fluid accumulation syndrome, global increased permeability syndrome, and you stop fluid removal when again there is fluid responsiveness and hypoperfusion. So it's important to choose your targets, triggers, and safety limits, because the goal is to avoid this global increased permeability syndrome, or the Michelin Man, which is a persistent positive cumulative fluid balance with organ failure related to the capillary leak. So especially it's pulmonary edema, it's venous congestion, it's abdominal hypertension, and so forth. Now, it's interesting to understand that based on the trajectory of the patient, the cumulative fluid balance can be important in predicting outcomes. And there is kind of a turning point after a couple of days where the patient will either further accumulate, remain accumulated, or evacuate spontaneously. And these trajectories have prognostic value. Also, if you would start renal replacement therapy and aim for a 0 to negative fluid balance, like in blue here, the patients in red will remain positive. Now, when it comes to cumulative fluid balance, the ideal curve is like a bell curve, initially positive and then normally evacuation. Because if at the tipping point the patient is not evacuating spontaneously, this will increase morbidity and mortality. And many studies have shown that a positive fluid balance is an independent predictor for poor prognosis compared to liberal, when we compare liberal versus restrictive strategies. Because once we are administering fluids, there will be second and third space fluid accumulation, increased abdominal pressure, there will be ileus, compression of the vena cava, a reduction in the blood flow to the heart, cardiac output will drop, and this will result in forward failure and a vicious cycle, leading to administration of more futile crystalloid fluids. So the fluid accumulation, what we see at the outside, the pitting edema, mirrors fluid accumulation at the inside. Each and every organ will be congested. There will be venous hypertension, and there will be this global increased permeability syndrome, Michelin man. And if you go back tomorrow to the ICU and the relatives ask you, why is granddad so puffy, swollen up? You're not gonna say this is just cosmetic and nothing to worry about. No, it's not cosmetic. It may be a sign of poor prognosis associated with ongoing infection, poor source control, so maybe you need to perform an ultrasound, change the antibiotics, or check for an abscess. So it's nothing cosmetic, it is important to dive into. Now, when we have fluid accumulation syndrome, we have to manage these patients. So prevention is key with the restriction and the withholding of the fluids. We have to care for these patients with careful monitoring, and we have to cure them if needed with diuretics and renal filtration therapy. Now, one more thing, which is about the facts on fluid stewardship. This is a study of a medical audit done by Johnny Wilkinson, who found that patients are receiving 9 times too much sodium and too little potassium. You probably know where this is. This is a statue of the Little Mermaid in Copenhagen. There lives Anders Perner, and he published this study on issuing of fluids by the pharmacy in Denmark, and about 70% is saline. And this was even higher in internal medicine departments. Now, you probably know or don't know, this is a landmark building in Brussels, in Belgium. And as you're never too old to study, I just finished a master and presented my master thesis on insurance medicine, just because of the fact that I'm consulting for patients and relatives when something goes wrong. And what we often see is that patients are subject to late detection of sepsis, fluid accumulation syndrome, and unrecognized intra-abdominal hypertension. Now, in this study, we looked at the issuing of fluids in Belgium over 10 years. We had about 4 million data lines, and on average, patients receive 11 million liters of fluids in Belgium. Data came from a hackathon, and we were able to connect to these data the type of fluids, the amount of fluids, the volume per patient, as well as per bed occupying day. So we had over 4 million data lines, and we had 1,250 million of individual IV fluid or drug administrations. Now, the data came from procurement, admission. We integrated the data, was anonymized, and I will skip here and go over to the results. One important thing is that for this 10-year period, we looked before and after 2012. Why? Because that was exactly the recommendation of the pharmacovigilance risk assessment on starches in 2012, where at the end it was stated that these fluids could no longer be used in sepsis, AKI, burns, and so forth. So for this data, huge data, we had to define in retrospect the different indications of fluids. So we said resuscitation fluids are isotonic. Remember the beakers with the body distribution, isotonic fluids will remain 25% intravascularly. Maintenance, we defined, and nutrition is clear, amino acids and lipids. Maintenance is any glucose-containing fluid. Dilution, we defined as the small bags, 50 ml, 100 ml. And the drugs like paracetamol, coming IV, metronidazole coming IV, so those were defined as creep fluids and the others to cover the daily needs. Now, we could not retrospectively define replacement or redistribution fluids, and we omitted the contrast solutions. We defined some key performance indicators like the fluids per patient, the fluids per day, and we looked at dilution, maintenance, creep, and resuscitation fluids. So the best dilution is glucose, the best maintenance is hypotonic balanced, creep should be avoided as much as possible, and resuscitation should be isotonic balanced. Now, totally 11 million liters of fluids per year, as you can see, and there is kind of an increase in resuscitation, so the isotonic ones, and a decrease in maintenance. If we compare 2007 and 17, we see creep fluids increasing, maintenance decreasing, but resuscitation increasing, which makes me think or believe, I'm sure, that many patients receive saline, ringers, or plasma-light as a maintenance solution rather than a resuscitation solution where it should be given for. Now we can see the trends. In gray is the 10-year trend, and in red versus blue is before and after the PRAC recommendations. So you can see that everything is on the rise except maintenance and nutrition. But if we look at the saline use, is an increase, also balanced crystalloids, plasma-light an increase, whereas starches, we stopped using them, so it looks like the recommendations were being followed, but you see an increase in albumin. These are the KPIs and the evolution, so the liters per patient and per day, they are dramatically increasing, as well as for dilution. Let's continue with the lectures. So I was sharing what happened in Belgium with regard to the issuing of fluids. And we noticed a lot of differences within the different regions in Belgium and the different provinces. You can see in some provinces they give 4.6 liters per patient, but in others it's 6.8 liters per patient. Over the years we see hopeful trends, so we see a decrease of the saline use, but still it's 65% of all isotonic fluids, and that is similar to what Anders Perner in Denmark has found. If we look at the evolutions and heat maps in Belgium, 2007 and then 2017, we see that admissions are increasing, bed occupying days are roughly the same. But if we look at the liters per patient, in 2007, on average, it was 4.7 liters, and in 2017 increased to 5.8. In the bottom, you see the liters of saline, which was around 1.72 liters, and it drastically increased, especially in the southern part of the country, up to 2.5 liters of saline. And the same trends in the liters per bed occupying day, from half a liter to almost 1 liter, and also the saline use, you see that the country is coloring more and more red, so we're giving more saline still. If we look at where the fluids are issued, is the medical department and the surgical department, but you see the ICU is a big spender, as well as geriatrics that is on the rise. Now, over time, if we look at the departments that perform best, it's the surgical department, probably because ERAS protocols are in place and the patients are getting lactated ringers or plasma-light standardized, but maybe not for the right indication. The internal medicine department is doing worst, with still about 80% of saline of all isotonic crystalloids, and the surgical department is around 45%. Burns unit is performing well, and ICU is also doing better. Now, what we need to prevent is this fluid accumulation syndrome, as I illustrated in my personal case and the other case after abdominal sepsis. Why is that? Because it, to me, could be a latent medical error. It's a wrong treatment, it's a complication, and it should not happen to the stage that the patient suffers from fluid accumulation syndrome. Because these complications, they are not cosmetic, and I can't stress more, they are not benign. They can precipitate a cascade of organ dysfunction and death, and also legal repercussions for healthcare providers because they are liable of poor patient care. Now, the other aspect is that if we give less fluids, we could save spendings. And if I look at the Belgian data, where we now have 5.6 liters per patient, maintenance 1.7, dilution is 0.5. I see there is an iPhone in the waiting room, so we should probably not accept the iPhone. Resuscitation fluids in Belgium, it's 2.5 liters. And if we translate the findings from the literature to the Belgian data, we could save about €7 per patient, which would be around 15 million a year. Now, studies have been performed looking at the little bags, the dilution fluids, the creep fluids, basically to give antimicrobials, vasoactive drugs, the noradrenaline, the dobutamine, electrolytes, sedation drugs. So these form the fluid creep. And studies have shown that if you reduce the volume of your drug diluent, you can reduce about 50% of your creep fluids. So translating that into potential cost savings in Belgium, we could maybe save up to 25 million a year, probably around 20 million. And this is the Belgian Minister of Healthcare who is doing a big round of cuts in spendings for hospitals. So this may be helpful. So to summarize and to end up, I think the clock is ticking and we can do better. And what we should do is the 8 rights of fluid stewardship. Is the right fluid, dose, rate, duration, de-escalation, indication for the right patient at the right time. Don't give the fluids if the patient does not need them. Now, I showed you the mermaid, I showed you Brussels. This I had to look up. It's Beautiful 5 in Scotland, where lives Marsha McDougall. And Marsha and her team were the first to implement the NICE guidelines, and over about 7 years they were able to reduce saline use. They stopped Hartmann, introduced plasma light, and they introduced a hypotonic balanced maintenance solution. By doing so, they are saving about 80,000 British pounds a year, and they reduced the fluids. Now it's about 0.3 liters per day, and it's about 3 liters per patient that they are issuing. You know, the atomium in Belgium, when I was the director of the ICU in the university hospital, when we implemented fluid stewardship, we were able to reduce the liters per patient, of course, on average for the whole hospital, and the liters per day from 0.6 to 0.4. So it is doable, it is achievable, and we can do better by implementing fluid stewardship. So I hope I convinced you that IV fluids are not just innocent bags of water. They are not. They are real drugs, medications that come with indications, contraindications, and potential adverse effects like peripheral edema. Anasarca is not cosmetic. It may be a sign of poor source control. I'm very happy to share that with the European Society of Intensive Care Medicine, we published 3 parts on the fluid drug. Part 2 was on the dose, and part 3 on de-escalation has just been accepted and published. This kind of summarizes it all, the different phases, the ROSE framework. Remember this, think about restriction, withholding and withdrawing fluids, think about Scylla and Charybdis, and finding the balance. Now, why wait? Start now. And this is a warm invitation to take the Fluid Champion course on the members portal, where we have lectures, quizzes, and theoretical parts. And it's completely free. You can earn about 12.5 CME credits. Then, if you finish it, you become a Fluid champion. And if you can identify in your hospital a team of doctors, nurses, pharmacists taking the basic fluid champion course, you can start your path to become a silver, gold, or diamond center of excellence. And in the members portal, you can see the world of the Fluid Academy, where we are happy to announce the first center of excellence in Kuwait, the Al Amiri Hospital, under the leadership of Abdul Rahman Al Fares. So maybe in the future, your hospital will be listed there. We provide you with guidance like the 6 steps to the silver and then the gold and the diamond label. I hope you enjoyed the lecture, and whether you like virtual meetings or webinars like this one, hopefully not hacked in the future, or in-person meetings, we are here with the Fluid Academy to assist you. And just the upcoming webinar will be on point-of-care ultrasound, and we will have, the end of November, a physical 2-day training course on fluid management. It's always a lot of fun, and this was IFAD Days in Joburg, and this was in Durban in South Africa, which were the first IFAD minis on the African continent, and maybe hopefully in the future we will expand. But it's difficult, and it's a delicate balance between hypovolemia and hypervolemia. Please join the International Fluid Academy. Thank you for your attention.
Thank you very much, Professor Manu, for your excellent lecture. You've guided us through the principles of fluid stewardship. You started by talking about the balance between hypo and hypervolemia, Scylla and Calyptus. You've told us why we need to give IV fluids. You've given us some pictorial evidence from an electron microscope, I guess, showing how the capillary gaps are and how they leak, and for us to know that these leaks could occur fast and could occur at a distance from the insult. Given us a pictorial evidence of the glycocalyx, which controls flow of fluids in the capillary. You mentioned a lot of studies. I'll try to mention a few. Andromeda study. You talked about fluid accumulation syndrome, which quite frankly, I have been experiencing in my ICU. And on my own, I was like, I think maybe we need to review fluid for elderly people because they tend to get bloated. You talked specifically about the secondary abdominal compartment syndrome, which could be a killer. You introduced us into fluid stewardship. IV fluids are necessary for patient care, but are a double-edged sword. Over 80 to 90% of patients get IV fluids, but 1 in 5 may suffer complications due to over or under dilution. 50% of healthcare workers have gaps in fluid knowledge. Gave us the D10 definition, diagnosis, distribution, the right drug, dose, duration, de-escalation, documentation, diligence, and discussion. And septic fluids, patients need fluids, not all. Some might be vascoplegic, and they might need pressors more fluids. I've experienced that myself, so yes. And then we talked about 7 hours resuscitation, routine maintenance, replacement, re-energize, which is nutrition, redissolving drugs, redistribution. I hope I didn't mix it up, but going through the R's. And then this beautiful concept, proven, ROSE, where R is for resuscitation, O is for optimization with fluids, S for stabilization, and E for evacuation or de-escalation. Normal saline is not normal, and you've pointed out to us why and how. And that balanced solutions are better. So our aim is to treat the patient, avoid fluid accumulation syndrome. You gave us a very good background of a 10-year study on IV fluid use in Belgium. And for me, very fascinating. And Ringer's lactate is an excellent fluid, a bit better than normal saline. Normal saline has its challenges, which you listed out. And then we talk about the challenges of maladministration of IV fluids, increasing patients' morbidity, increasing patients' mortality, increasing cost, and has medical legal implications. Invited us to join the Fluid Champion course, which definitely I'm going to join. And we tried to set up a fluid team in our places and wherever we're located. Definitely, I'm going to do the course. And then very kind of you, you gave us the link. The link is provided to download the free book. I believe a lot of us will benefit from all these. Once again, we thank you very much for your excellent presentation. At this point, we ran a bit over because of little technical things, and we overcome difficulties. That's why we're healthcare workers who are strong. What we do now is check if we have questions from people. Okay, I've been talking a lot. There are a few questions here. Forgive me. Okay. Pediatric, let me see. Thank you so much for the informative from Mosina Pasha. Thank you so much for the informative insights, Prof. A pediatric intensivist here. Although fluids are calculated much more meticulously in children, we do still end up having FAS more often than we would like. Looks like capillary leak hits all age groups similarly. Okay, that's more of a comment than a question. I do.
If I may, for pediatrics, there is the ongoing discussion and the fear for hyponatremia. So for adults, it is now clear that for maintenance, we give hypotonic solutions. But in children, there is still an ongoing debate where isotonic solutions still come in a first choice. But for the balanced, I think also in children, you should go for balanced solutions rather than saline.
Okay, great. Aliyu Haider says, thank you for the lecture. In resource-poor setting where we don't have much of the equipment for monitoring, how can we practice this fluid stewardship?
Yeah, is a very good question. So it's twofold. So in resource-limited countries, what kind of monitoring can we do? If you don't have a fancy cardiac output monitor or a pico device or an ultrasound device even, I think careful monitoring of daily and cumulative fluid balance, daily and cumulative body weight, if possible, as well as for perfusion. I think the Andromeda study showed that the capillary refill time could be a good surrogate for lactate if that would not be available. So I think there are some simple things that we can do even if resources are limited. I think maybe ultrasound would be the easiest to seep through because it can be implemented in different departments. It's not confined to the ER, it's not confined to one patient. So if you have ultrasound, that would be key to look at the VTI of the left ventricle outflow tract, to look at variations, to look for fluid responsiveness, and then also the other spectrum, fluid accumulation with a VEXA score, looking for congestion, looking for B lines in the lungs. So fluid unresponsiveness may even be more important as a safety parameter because it tells you that the patient may be ready for de-resuscitation if he's not doing this by himself, and giving some furosemide, like a furosemide stress test, which is a very simple test. You give 1 milligram of furosemide for those who are naive to the drug, or you give 1.5 milligrams per kilo for those who already are on the drug. You wait for 2 hours, and if urine output is above 200, then the patient has passed the test and maybe is ready for de-resuscitation. So yes, there are things that we can do in resource-limited places, and I'm actually sitting together with colleagues from Africa and the Global Sepsis Alliance and we were thinking of a working group on fluids in Africa and what we can do with respect to the type of fluids and the monitoring. So I invite everyone to join the Fluid Academy. It's free. Become a fluid champion. It's free because this is the policy of the society that we should be here to deliver free, open access medical education to you all. And as said by Dr. Affiong Elumelu, if you become a champion and if you go back to the hospital and you can convince a pharmacist, a nurse, another doctor, you can build a team and you can drive the change towards fluid stewardship in your hospital.
Okay, thank you, Prof. I have one other question here from two questions really. Elva Alejandra Pedraza Cortez. She says, she's asking, the septic patient, which is the best solution, colloid or crystalloid?
Yeah, is a good question, but we have to remember that every fluid will be lost to the interstitium. It's just a matter of time. So all fluids are redistributed. I told you that in sepsis, if you would give saline or a colloid, the saline will remain intravascularly 25% for an hour and the colloid 100% for an hour. But eventually, the transcapillary escape rate also for albumin is about 5% per hour. So after 6-8 hours, you have a half-life that has been reached, and your albumin will be lost as well. So the guidelines say 30 ml per kg within the first 1 to 3 hours, and after that, maybe you could think of introducing colloids. We don't use starches, we don't use gelatin, so the only one left is albumin. Would then be albumin 5%. We rather use albumin 20% because it even allows you to give less volume. But the big point is that just looking at the patient clinically, if you have a very low diastolic blood pressure, 40 millimeters of mercury, if you have a diastolic shock index, heart rate divided by the diastolic blood pressure above 2.2, then the patient probably is vasoplegic and vasopresses, early vasopresses, so you don't have to wait for the 30 ml per kg to give, can recruit the fluids from the unstressed to the stressed volume. So it's like an auto-transfusion, a synergistic effect, which allows you to give less fluids for the same beneficial effect on perfusion and cardiac output. So that would be my recommendation. Don't give saline, give ringer. If problem with ringer is it's as a sodium of 130, so it's a little bit hypotonic. So it will not remain as good intravascularly as compared to saline, but it's better with regard to acid-base sodium and chloride effect. So if you have ringer lactate, I suggest to use it, except neuropatient, traumatic brain injury, and if you have upper GI losses, if you have a metabolic alkalosis, then you may give saline.
Okay. I think what would be the last question here? I'm not sure I understand this question. Kindly tell us about the comorbidities and the fluid management. Can we implement protocol case by case, especially post-operative?
Yeah.
I think that's a bit...
I think it's if you have a patient, for instance, with comorbidity like kidney disease or cardiac disease, cardiac failure, liver disease, endocrinology disorder like diabetic ketoacidosis. So definitely, or neurologic problems, it definitely is true that you have to go for protocolized care. But I think better we should go for personalized care and even better individualized care. And let me just define this because there is a lot of confusion. Protocolised care is like surviving sepsis guidelines. A blood pressure 65, you need to give everyone 30 ml per kg. Personalized care is taken into account comorbidity, a patient with hypertension. So maybe he doesn't need 65, but he needs 75. So we personalize the treatment for that patient, and then we follow the protocol. Individualized goes even a step further. So it may be 75 on day 1, but maybe on day 2, there may be another parameter, like we focus on the lung water or the intra-abdominal pressure. So individually, dynamically, over time, we individualize our treatment.
Okay, I think that's the last question we have. Once again, thank you very much, Prof. I am grateful personally for this lecture and the opportunity to join the IFA and to download the book, because a lot of what you've presented is a lot of what I've been thinking about recently in my ICU. I handle more of elderly people, and it's you really individualized fluid care for the patients. So I think we've spent more time than we had planned. Once again, on behalf of the Intensive and Critical Care Society of Nigeria, we thank you very much, and we hope to have a better, long-lasting, continuing professional relationship with you. I will hand over back to Dr. Irene, the president of the society, to give closing remarks.
Thank you very much, Dr. Affiong.
Thank you. Okay.
Thank you, everyone. I'm Dr. Irene Akidino. I'm the Vice President of the Society and the Chair of the Education Committee. And would like, on behalf of the Education Committee, would like to sincerely thank Professor Manu for accepting to give this webinar. I'm really glad he accepted this invitation. It was quite a short notice. I know I had to badger him with his busy schedule, and I'm sure a lot of us have gained maximally. We would also want to apologize for the unfortunate event we had, and then we hope to improve on our cybersecurity space, especially for our webinars. I would like to also thank members who have joined, and colleagues and friends from not just Nigeria, all over parts of Africa. I would like to also specifically thank the founder of the Egyptian Society of Acute and Critical Care, Professor Sapa, for joining, and a lot of colleagues in adult medicine, pediatrics, emergency, and not just ICU. And for our friends from all over the world who have joined to listen to Professor Manu to create this knowledge for us. I would hand over to the president of the society, Professor Job Otokwala, to give the closing statement. Thank you very much.
Well, thank you very much. Thank you, Professor Manu.
Hello, Dr. Job.
So, thank you very much, Professor Margaret. Thank you, everyone, for the privilege you've had today to listen to our authority on fluid management. We can't thank you enough for offering us this body of knowledge. And that's what we need to manage our patients. We need knowledge to drive our practice. I want to make an appeal to you. If it's possible for us to have more time to learn about the physiology of fluids, from the basics to the bedside. If it's possible to have access to such pieces of information, that would be very useful to all of us. Thank you. Like the moderator said, we need to have more collaboration between our society and your body as well. And that will help us. We have a large number of young people who are interested to learn more about medical care, about all this aspect of care that are very relevant to our practice. Thank you, our immediate past president who has been around. We are sorry for what happened, and very senior colleagues across the globe who joined this webinar. the next 2 months, we'll have some privilege to learn more. And I also even employ the speaker to help us talk to his colleagues. You can also join us. Actually, the basics. Applied physiology in critical care is what we need to drive our projects back home. So I can actually make some adjustments to what we are traditionally used to do. Thank you very much. I want to urge all those who are not members of our society to remember to join us. We'll send the link to the platform or to this platform as well, and to our society's platform, or would be members to join. Thank you. Good night. Have a nice day. See you next time.
Okay, bye-bye.
Thank you, Professor Manu.
And
Thank you so much.
let's stay in touch.
Thank you. Thank you very
Thank
much.
you.
Yes, thank you so much.
Bye.
Thank you.
Thank you very much. Thank you, everyone, for joining in. Thank you, Professor.
Thank you. Bye. Bye.
Thank you so much.
Well done.
Thank you all for joining in. Truly appreciated. Thank you, moderator. Members of the education committee, thank you very much. These hackers are something else. I don't, and they hack into the person presenting. So it's they take over the screen.
Yes, it's difficult. It has happened to me before, so I know you can't remove them.
You can't
I'm still
remove them.
in
You have
shock.
to end the meeting. Yes.
I'm still in shock.
No, it's as if they are going around the web, strolling around the web.
They do it routinely, and it's usually pornography. This one is not even bad. There was one that it was females, and they were doing the act, male and it was.
But why are people just disruptive? As in, why? I wonder what they say.
That's unfortunate part of modern living.
We were not even fast to identify it, and then long off.
Yeah, that's why I was raising alarm. Job.
No, they saw it. I saw it immediately.
That Job was not the host. The president was.
Okay.
That's why I have to try and get across to Dr. Jedo. It's only the host that can end a meeting. A co-host can't end a meeting.
Yes, ma. By the time I even realized that trying to end the meeting can solve the problem, that was when call kept on coming in, and I cannot press the phone. It's the same device. Initially, I was trying to remove him. If I've removed like 3 people, but because they hijacked the host, it was the host that was hijacked.
Yeah,
I mean, it was the presenter rather that was hijacked. So they are using his screen and everything, because 2 people cannot share slides together on the same. So it makes it difficult. Thank you for just telling us to end this, because I never had that experience before.
Yeah.
For me, it's a learning experience. It's a learning experience as an individual and as an association. I think we'll probably, as you said, improve our cyber security.
But the thing is that
there's really nothing to do, because they have very superior, these viruses that are very powerful. So it doesn't depend on you or whatever you do. Zoom is an open this thing. It's air. And anybody that has the link can access it. So they enter people's.
He was even trying to call Affiong's name. God, I
said my name finish now.
He called her name. He was not trying to accuse me that I'm like an African. I was saying end the meeting. He was repeating what I'm saying. Yes. The way my accent is, I said, foolish man.
I guess I don't know. We'll see how we can discuss with Zoom provider. Yes, and see how.
What are you
to discuss that later, so we can end the meeting. I think we can end this. Then we'll discuss that later.
Okay.
Good night.
Warm regards to everybody. God bless. Have a lovely Sunday.
Yeah, you too. Bye. Thank you.
Bye-bye.